blood perfusion is not sufficient, when the blood perfusion is not sufficient for the heart to perform its job, is ischemia. Okay, you know that. So I'll just close the door. Okay. So I have been telling you that MI is one of the worst. It's not one of these, the worst complication of ischemic heart disease. So I told you previously that there are stages of this ischemic heart diseases. That is myocardial, ischemic heart disease. That is angina pectoris. And when the angina pectoris pain is failed to improve after you give nitroglycerin, that is nitrates, if you remember yesterday's class, and it is not subsiding, and the pain is continuing even after half an hour of the initiation of the pain, with nitroglycerin being provided, and the person not performing heavy exercises or at rest, and these measures are failing to improve the pain, then we call it unstable angina. Sometimes nowadays the modern nomenclature is that this non-ST elevation MI. Okay, this is called non-ST elevation. ST elevation, you know that there is a segment. You know the waves of ECG, PQRST. Okay, ST elevation is the segment ST that elevates up because of this infarction in the acute phase. In the later phase, it may go down. It will go down in chronic phase, but in acute phases, it will climb up. That is one of the earliest detection methods we have. Okay, when you go and check for ST elevation, then it is confirmed that the person is suffering from already involving MI. Okay, so this how I started this ST elevation is that this unstable angina sometimes is called MI, but non-ST elevation MI, and the methods of treatment will be quite similar to this of ST elevation MI. Okay, but today we are going to talk about ST elevation MI, which is nothing but it is just abrupt, not like stenocardia. Half of the blood vessel is blocked, and very little amount of blood vessel is blocked, and very little amount of blood is being passed through that constriction. It's not that. It's most frequently it's abrupt occlusion. How it can be abrupt? So if you find if there is an atherosclerotic patch, and then platelets are aggregating and joining together on top of that atherosclerotic patch, then there is a real chance that platelet aggregate that is formed there might either itself block there only, or it may get detached and then travel to more narrow portion of that blood vessel and block it completely. When that happens, then there is no chance that blood is perfusing adequately to the affected area from that occlusion. So if not intervened properly in time, then the portion which that particular artery would have supplied will die sooner or later. Okay, so if MI is already occurred, then our job will be first to save the life of the patient, and then to limit the size of infarction. Okay, infarction you can see will be there somewhere in the heart wall. Okay, the smaller the infarction size, the better the chance of the patient to survive. Larger, the patient will die. Okay, and I'll tell you again in the coming slides that most of the deaths do not even reach. Most of the cases do not even reach the hospital. They die in the place. Okay, very big chunk. Okay, and the only others that survive that initial phase, we can help them. So how can help them? So this nucleus of necrotic tissue that's already been evolving, forming, the core of that nucleus of that necrotic patch, necrotic mass is already necrotized. It's already dead. So our job here is to prevent the surrounding non-necrotic but ready to go necrosis. These portions we can bring it back to normal. Okay, so that those are the immediate purpose we have for MI. Okay, so we'll talk about all these treatments and what is this detail in the coming slides. We'll start with a lady who with a case. Okay, so there is a case, Julie Shrestha, 60 years old lady. Okay, you can see in the in the slide. Are you able to visualize my slides? Yes or no?
Yes.
Okay.
Yes, sir.
So okay, okay. So a 60-year-old lady, Julie Shrestha, known case of angina pectoris. Known KCO is known case of, okay. Known case of angina pectoris is was returning home after okay, this is okay, known case of angina pectoris was returning home after visiting her friend's house. Suddenly, she felt pain in the chest radiating to the left arm and shoulder. Okay, I have mentioned this is the known case of angina pectoris. Okay, this means the female already knows what it is. Okay, so not only she knows what it is, she has that nitroglycerin in her pocket. Okay, so and the people who regularly get this type of pain will know when it is going to develop. Okay, so they will immediately take this nitroglycerin sublingual. Then they might feel better. Okay, but this time what happened is she took 3 times, one after another, in 5 minutes interval. She tried all of them, and she knew that this is something abnormal. So she called for help because the pain was not relieved after that, and help arrived. Okay, and she and then she was taken to the hospital. Immediately, the medical officer took an ECG. Okay, that is the first thing that we do in emergency department to identify if it is myocardial infarction. And those cases where we have to differential diagnosis, we have to diagnose differentially if it is MI or not. Okay, on all chest pains are not peculiar like classical angina pectoris with radiating to the sites we discussed. But there are other cases which are non-peculiar, as well as there are cases we need to differentiate from. For example, if it is very severe gastritis, the pain might be same. Okay, there might be some muscular pains around in the muscles and the bones that should also be differentiated. Okay, for that we are doing this ECG, and you can see this ECG is ST segment elevation. You can see P, Q, R, S, and T. This is T. Okay, so you can see normally it should drop down. Okay, here, and then T should be here, isn't it? So, but this segment ST segment is elevated up. So this is what we call ST elevated MI. Okay, so for this lady, in the lead second, lead third, and ABF ECG leads had this type of ST segment elevation. The okay, and then immediately she was provided all the life threatening or life-saving measures like oxygenation. I'll talk about that. All the measures were done in the emergency department, and her blood was taken for these markers: CKMB, troponin, INT, LDH, AST, and pathology, I think. So I'm not going to go detail. These are all enzymes. Okay, enzymes, cardiac enzymes, CKMB, CPKMB, and troponin G. And these are product of lysis of these cardiomyocytes, muscles. Okay, so when there is lysis of muscles occurs, then the enzymes inside those cells will get out of these cells, and then you go to the blood, which in normal conditions they are not in blood. So if we check this, if we find these enzymes in the blood, then this is confirmatory that there is some sort of muscular damage. And CKMB troponin, they are highly cardioselective. There are other markers like myoglobin is also elevated, that but myoglobin has a problem. It cannot differentiate cardiac muscle or heart skeletal muscles. Both of them will liberate myoglobin if it is destroyed. That means it cannot differentiate from infarction of other tissues or destruction of other tissues, injuries and other things, diseases, muscular lysis diseases, myositis, and all these things won't be differentiated. But these enzymes all were elevated in that case, Julie Shrestha. So she was diagnosed as MI. Okay, so this is the classic picture I wanted to show you what happens in MI. Okay, so we'll go to the proper topic now. Okay, principles and treatment of acute myocardial infarction. Can see the okay. You know what? Several times I've been discussing about this. You can see this portion here. The artery is occluded over here. You can see, and this darker red side is the site of affected site. Okay, the darker red is the site where it is starting to necrotize. So this one over here. So this is relatively smaller anterior apex towards the apex of the heart. I'm sorry, base of the heart. So this is basal myocardial infarction. It might be anterior wall, posterior wall, lateral wall, septal. Okay, septal portion, or it might be pan. Okay, all over your heart. So if that happens, then the death is inevitable. The patient might not even survive till hospital, because if it is whole big chunk of muscle of your heart, then obviously it will not be able to pump. So the complication here will be pump failure. Most of the times, the initial death of the patient might happen it can happen in two different ways. One is electrical failure. Electrical failure will happen because of this conduction problem. Okay, so you know that the heartbeat started from SA node and then propagated to AB, and then from there it will disperse throughout these ventricles by Purkinje fibers, and then muscles will contract. So you know that all those physiological processes happening over there, but this thing needs conductivity of these neurons and this pathways, okay, nerves. So these fibers, if it is infarcted, then they might be no longer able to conduct the electricity. If that happens, there might be block. Okay, if it is just above the AV node, then that might be AV block. If it is in the sinoatrial node, that might be completely deaf, because sinoatrial node is no longer giving the impulses. It might be in the Purkinje fiber type of areas, in the ventricle wall. Then again, there might be abnormal conduction of electrical current over there, and then some portion will not move. Okay, or there might be because of increased apprehension or increased disturbance in the heart conductivity system, there might be a rise of arrhythmia. Okay, so both of these are electrolar failure. Okay, arrhythmia happening, or tachycardia, bradycardia, blockade, any type of abnormal heartbeats, that is the primary cause of death immediately. Okay, and then after that, there might be mechanical failure. The electrical circuit might be more or less being performing well, but the muscles are no longer capable of squeezing the blood out adequately. That means the blood rushing out of the blood heart is not able to reach every nook and corner of your body. Okay, if that happens, then there's obviously that is heart failure, acute heart failure, and the patient might die from that. Before going to abnormal ones, I'll show you normal and abnormal ECGs right now, but I cannot go in detail. But this is a very vast topic. We'll learn in the higher classes when you go to cardiology class, medicine in MTH. Okay. So you know, just I showed you to show you what are these intervals. Okay, PR interval, this P wave, PR segment. So from end of P to the initiation of Q, and then Q wave is this one, R, the largest one, and then this S being QRS complex. Okay, QRS complex will show how ventricles will contract. Okay, and ST segment is from the end of S to the beginning of T. This is the segment that is acutely elevated up. Okay, and T. You know what are the functions of all these things? P is the wave that will show if sinoatrial node has produced any impulses or not. Okay, if sinoatrial node is not there or it's not functioning, then P wave will not be there. That is why if there is absence of P, and then we call this ECG, this beat, as the impulse is generating from AV node, not from sinoatrial node. Okay, so and this PQRS is always not biphasic or triphasic. Okay, either Q will be positive, R will be negative, depending on which lead you are going to see this ECG. Okay, and what is the basic function? Okay, I'll get to that. So after this QRS complex, this is all about contraction of ventricles, and then after this small pause over there, this T is elevated, which is repolarization of heart. Okay, next time the heart needs to contract, which will be depolarized. So while contraction, the heart needs to get depolarized. So to get depolarized again, it needs to repolarize back. Okay, to get ready for this acceptance of this charge. So this is what T signifies. Okay, without T, the initiation of another round of ECG or PQRST will not be there. Okay, it is not possible. So I was telling about how these waves form. Okay, so basically when you take a wave ECG, you have leads. Okay, you have leads like chest leads 1 to 6. Okay, and first, second, third lead, and AVL leads, which are complicated leads from your hands and feet. Okay, so that means what is this is whichever lead is registering your ECG will show a different kind of pattern. What happens is that the charge from the heart starts from the sinoatrial node and then slowly propagates down, and every portion of the heart, they have different speed of propagation. Okay, and they'll turn around from left to right, right to left, and that is very fast. Okay, this is one beat. In one beat, all this propagation of electric current, movement of the current is recorded. Okay, and that movement is, if towards the lead that registers your ECG, then it will give you a positive sign, positive wave. If it is away, if it is moving away from that lead, then it gives negative. Okay, that means if your lead is just above your SA node, then this P will be always positive. Okay, and if it is there only, and if the electric current reaches the ventricles, then ventricles is big enough, so there will be a complex type of movement. From left side it will go down, and maybe from the right side it may come up, so that will be averaged out. Okay, and then the resultant vector of the direction of this flow will be registered in the ECG. Okay, so that is why if some person is not able to conduct adequately or normally these electrical currents, that will be registered. Okay, that will be if some portion is lagging the conductivity, then that will be successfully registered here in this ECG. Okay, how will it be registered? You can see this is a real ECG, and I can tell you that this ECG might be of that Julie that I talked. Okay, so I told you that the ST elevation is in 2, 3 and AVF, 2, 3 and AVF. You can see there are ST elevations over here, and there are ST depression over here. Why? Because from the prospectus of lead 1, the current is moving away in the direction towards the opposite direction in that pathological area. Okay, but in AV2, the overall direction comes towards it. So there you can see this is elevated here. So if there are 3 elevations in one set of ECG in 3 leads, then most probably this is all MI. Okay. So aim of the therapy of MI. So this is very important. The first thing is initiation of treatment is should be rapid. Okay, guys. And in most of urban areas, this late of lag of onset of pain and reaching the hospital is not because of acute transportation or something like that. What happens here is people who are not aware will seek help late. Okay, and while they'll think that pain is there and subsiding, and if it increases, then they will source for help. So that time should be minimized. All the high risk patients should be informed adequately when you should seek help. Okay, so acute stage is up to 7 days, where we are concentrating in saving the patient's life. Okay, first few hours are the most critical ones. I told you last time in the previous slide as well, the vast majority of these cases will die within 24 hours, and half of these 24 patients will die in the first hour itself, never reaching the hospital. Okay, so saving life, and then second is you have saved life, you have taken measures to save the patient's life. I'll tell you what are the measures. And prevention of irreversible ischemic damage. Okay, if it's already evolved, already established MI, then also the central core of the infarct tissue will be necrotized, and the other surrounding tissues might be okay. They might be not yet necrotized, but on the process of necrotizing. So we can prevent that from, and then we can what we call as limiting the size of infarction. That is the aim. Okay, and in the stable healing phase from 27 to 28 days, 1 month, we can have so many secondary rehabilitation processes. Okay, light is off. Am I online?
Yes, sir.
Yes, sir.
Okay. Okay. Because of the electricity failure, I thought I might be offline now. So okay. So stable healing in angina is from 7 to 28 days, and there we concentrate in secondary prevention, means the already formed nucleus of the infarction is already there, but we have to prevent reinfarction in other tissues. Okay, because that clot is still there, and the risk factor for developing MI is still there in that patient, so we have to prevent that. And then rehabilitation. Why is it rehabilitation? Like narcotic addictions and other things, here the patient's heart is changed forever. The portion of the heart whichever was infarcted is now not working, so he has to live with the portion of the heart not working for the rest of the life. Okay, so how, what to do, what not to do, so the doctor will establish which part of your heart is not working and what to avoid, what not to avoid, what are the drugs you need to take for further after being discharged from the hospital. These things will be talked about. So this is the initially I'm giving you the summary of how to treat this, but later I'm going to elaborate that. Okay, so I'll start with this basis of treatment, what happens in the chronological order. Okay, so if there is myocardial ischemia, you can see the first thing that is apprehended that is there is cardiac pain, chest pain. Okay, so chest pain immediately the patient will feel. So and accordingly I'm going to give you what are the things we can use. Okay, for chest pain, the drugs you should give first will be nitrates. So and then if that is not sufficient, and nitrates is not just for pain. Okay, guys, you know from previous class, it relieves the pain, or and it will dilate the blood vessels to reduce the blood pressure. Okay, so that means vasodilatory action as well as coronary artery dilatation will be there. So not only for pain, it will even improve the overall condition, though it doesn't subside, it may not subside the pain, but it will work. Okay, and most probably if it is MI, then this nitrates is not able to subside, it is not sufficient, then we can use morphine and pethidine, drugs like morphine and pethidine to ease the patient off. Okay, and this will be given very fast, because this pain can sometimes lead to anxiety for this patient. Okay, if there is no pain, then there might be no anxiety and apprehension. But if the pain is very severe, then the patient may be he may be quite scared. Okay, scared of death. Okay, so this anxiety and apprehension is also a problem. For that, basically we give beta blockers. Okay, beta blockers to block this apprehension is sympathetic stimulation, isn't it? Adrenaline, loss of adrenaline and noradrenaline in the blood. Because of I think it might be because of lowered BP or because of the apprehension that we have. So for those, we can use beta blockers, and using beta blockers should be very cautiously done, because you know that here the heart is not able to pump, and beta blockers will decrease the inotropic effect, okay, of the heart. So that means it might sometimes be contraindicated. So you have to look for those signs and symptoms and then decide accordingly. I'll tell you about that. So more vasodilators can be given for to improve the cardiac, to decrease the cardiac walk. Okay, here some portion of the heart is not working, so you should focus more on reducing the load for the heart. So already nitrates is doing that, and now you can use more vasodilators that we talked about yesterday. Nitroprusside, sodium nitroprusside, you asked me yesterday, so that can be given here, and plus to treat arrhythmias. Okay, antiarrhythmic drugs should also be infused for this patient to control arrhythmia. Okay, and then to prevent further ischemia and to prevent further stop the evolving infarction, or to bring back the limit the infarction size, we can have fibrinolysis, fibrinolytic drug. We've talked about fibrinolysis, streptokinase, alteplase last time. I think we discussed about these topics. So these drugs can be given. Why? Because fibrinolytics are able to dissolve the clot, isn't it? Dissolve the clot inside already formed clot. So if you timely manner, if you dissolve the clot, then the infarction even might be limited to very small. Okay, and if not possible, then there is not only fibrinolytic, there is another thing that can reperfusion. This is called reperfusion of the heart. So that can be the PCI. Okay, percutaneous intervention can be done. So that can be. We'll discuss that in coming slides. So this worsen, and then the death, if we didn't help or the help was not sufficient, then the worsening of myocardial ischemia and then increasing the myocardial ischemia size will lead to the death of this cell, which is called irreversible changes in the myocytes, which we can do nothing about. Okay, so for now we are going to discuss what are the drugs used. Okay, so drugs used in MI, first is pain, anxiety, and apprehension. To effectively cope this, we can use nitroglycerin in mild cases, or if the person is severely in pain, then morphine, pethidine we talked about. Okay, and even to calm the patient down, we can use diazepam to reduce apprehension and anxiety, and these can be administered parenterally, okay, if needed. So, but you need to be careful that sorry, by giving this morphine and pethidine, there will be histamine release, which may cause hypotension. Histamine release will vasodilate. So we have already given vasodilation. We give other vasodilatory drugs, and then again we are adding this. So there might be problem with hypotension. Here, hypotension is not is a problem over here. We have to make the heart pump adequately so that the BP doesn't go too low. Okay. So this might be done by lowering or elevating lower limbs or getting all other fluid. Okay, but mind you that fluid should be given entirely if needed. Okay, the veins should be opened up and then this should be kept so that we can give intravenous drug quite fast. So opening the veins and keeping the IV line open is a good idea. to administer the drug. Okay, but giving fluid in high dose is not recommended. I'll tell you later on. So oxygenation by O2 inhalation is needed here, but mind you that this person is not COPD, is not suffering from, if it is not chest problem, then high flow of oxygenation therapy is also contraindicated because it can lead to oxygen poisoning. Okay, so we have to give 4 to 5, 6 liters per minute of oxygen. Not very high saturation of oxygen should be provided, and if needed, then assisted respiration or ventilation should be, ventilatory support should be there for the patient. For quick response team should have all these things ready in the hospital. Okay, so third thing is that we have to maintain the blood volume and tissue perfusion and microcirculation. Otherwise, this might be the cause of death. Okay, so again, I talked about this elevating the limbs and other things. That also is what we are doing there is elevating the lower limb. Is that we are providing the important blood flow towards the important organs. Legs here is not important immediately. Okay, so we have other organs like kidneys, liver and brain, so which needs sufficient amount of blood. Okay, so we have to improve that by giving IV infusion, slow IV infusion, slow infusion of saline, low molecular weight dextran. So this is glucose solution, which is very low molecular weight. We should always aim for low molecular weight things here. Heavy things again will be heavy for the heart to pump. So again, these things should be administered quite cautiously, so as you should not overload the patient. So because overloading the patient will have, again, the problem will be the same, that the heart is not able to pump. So these things should be done very cautiously. And correction of acidosis. The pain here, you have learned from pathology, I think. Pain here, heart pain, is because of production of lactic acid. Okay, so you have experienced pain after vigorous weightlifting, other things. I hope. Today you go to gym and tomorrow you have severe pain in your muscles. If it is your first time, why is that happening? Because your muscle was not, you are not used to that vigorous exercise. Your muscles did get the sufficient amount of oxygen, and the nutrients, the nutrients were broken down with anaerobic method. Okay, so that anaerobic method of production of energy is fast, but it produces lactic acid. Okay, lactic acid is painful. So the same pain here, the heart pain is because of lactic acid production, not in only in MI, but also in ischemic heart disease and xenobacteria. Okay. So due to this lactic acid production, the correction of acidosis should be there by infusion of bicarbonate. That means your blood is now acidic by infusion. And how do you know this? You have to test bloods for ABG. Okay, guys, arterial blood gases. So ABG will give you the saturation of your blood, amount of carbon dioxide present in the blood, amount of these buffer solutions like bicarbonates and other things. It will detect the pH level of your heart, of your blood. So if the pH is too low, too acidic, then we have to give bicarbonates to correct that. Okay. And another one is the prevention and treatment of arrhythmias. And if there is no arrhythmia, then prophylaxis. So infusion of beta blocker, until and unless it is not contraindicated. I told you what are the, if the heart is not performing well, BP is too low, then we don't do this. Otherwise, we have to use some beta blocker to prevent arrhythmias. And last, but it's not last, okay, the pump failure. If most of the cases there will be pump failures, so for those cases we have to use drugs like furosemide that will reduce the amount of circulating blood, and then the heart may find easy to pump. Somebody's mic is not mute. Please mute your mics. Okay, I'm getting the disturbances from somebody. So furosemide will decrease the level of circulating blood. Vasodilators like nitroglycerin, GTN, or nitroprusside. These are the drugs that will vasodilate and make the work easy for your heart. And if needed, and only if needed, inotropic drugs like dopamine and dovitamin. So these drugs might even worsen sometimes. Why? Because these are the drugs that will increase the load to the heart. We have to use this because the heart is now not being able to pump, and the patient may die because of any inadequacy of blood flow. So to prevent immediate death, we have to use dopamine or dovitamin, but it might have some adverse effects on the heart. So you keep in mind, you know why there might be adverse effect on the heart, because to cope with this decreased capacity of the heart, we have to decrease the amount of activity the heart does. But dopamine and dovitamin being beta agonist drugs, they will increase the heart rate and the work of the heart. So this might sometimes be a problem. So the next thing we are going to do is prevention of extension of thrombus, okay, extension and embolism in the secondary areas of a heart, and then again limiting the size of the same major infarction, okay. And not only that, because now the patient is going to lie down for a long period of time, he might develop things like deep vein thrombosis. Okay, we have learned heparin and other things in the previous classes. So these things should be used. Like aspirin is one of the most important drug, guys. Okay, aspirin immediately when the first instance of pain is there, you should patient should have this aspirin 150 to 300 mg tablet and chew it and put it around the mouth so that it can get absorbed immediately, and then this aspirin can work immediately. Okay, you will have pain as soon as there is occlusion, and aspirin will be there to not to let it grow further. Okay, so that means the growth of this embolus will stop right over there because of inability of these platelets to aggregate together. Okay, so immediately after you give this 300 mg, immediately when there is evolving MI, then after that you should continue 75 to 150 mg per day for longer period of time if there are no other contraindications. So thrombolysis and reperfusion. So we talked about thrombolytic agents like plasminogen activators, streptokinase, ureokinase, alteplase. So these drugs should be given immediately until and unless there are no other contraindications. You know what are the contraindications from the previous classes, and so this obviously will have a good reperfusion of the heart. Not only this thing. Not only that, we can have a percutaneous coronary intervention. Okay, not only this thrombolysis is in large centers like we have in our MTH, we can have angioplasty and stenting. Okay, angioplasty, this is percutaneous coronary intervention. From the skin, we find out which one of the blood vessel is occluded, and then we try to dilate that mechanically, or sometimes we can even insert a stent over there. Okay, so we'll find that blood vessel, place a stent over there. So if that sort of available service is not available, then we can go for fibrinolytic, that is called PCI. We are going to talk about that also. So after that you have saved the patient's life, then what we need to think next is prevention of remodeling and the subsequent CHF. Okay, now you have saved the patient. Now the heart might get enlarged. Okay, why? Because some portion of the heart needs to work harder because the other portion is not working. So because of that, the healthy portion will have overload, and then it will start growing hypertrophy out. Okay, and that will also create other problem. That for that, you know that AC inhibitors and ARBs, they are capable of blocking aldosterone also, if you remember. So these aldosterone antagonists can help in sizing prevention of remodeling or enlargement of the heart. Okay, not only that, it can prevent subsequent congestive heart failure. Okay, so one of the core reasons of congestive heart failure, the cause of congestive heart failure is MI. Okay, and since you know that this some portion of the heart muscle is not working, then obviously the full functioning of a heart is not there. So slowly the patient might go deteriorate and then develop chronic heart failure. Okay, for that you have to give the drugs accordingly. And for prevention of future attacks, for prevention of future attacks, platelet inhibitors is given, either aspirin or clopidogrel. If you remember from previous classes, we talked about aspirin and clopidogrel as well, thromboxane A inhibitor. Prevent for a long-term basis are routinely prescribed. Why? To prevent prevention of further thrombus. Okay. Beta blockers reduce the risk of reinfarction. So beta blockers will now modulate the working of the heart. Okay, it won't let the heart beat uncontrollably fast or uncontrollably briskly or forcefully. Okay, so it will modulate that function. It will prevent it from beating too fast. Okay, so that thing will reduce the risk of reinfarction and even CHF. Okay, if the incapable heart is given lots of work, then it might fail to work. Okay, so that thing is prevented from beta blocker. These platelet and beta blocker and even AC inhibitors are known to be preventing the mortality. Okay, the mortality is quite good with these drugs. All patients without contraindications are put on beta blocker for at least 2 years. And last but not the least is control of hyperlipidemia. You know, all these problems started from where? From atherosclerotic patch. So if you further ignore these hyperlipidemic patients, then the development of MI, secondary MI, subsequent reinfarction might be always there. Okay, so you have to either you have to use hypolipidemic drugs like statins and fenofibrates and others, or you have to prevent, or somehow by pharmacological or non-pharmacological measures, you have to reduce the amount of triglycerides and bad cholesterol in your blood. So I have been repeating these things for so many times now. Is a vast majority of the deaths occur in the first 24 hours. Okay, first 24 hours. With half of the deaths is from either electrical complications or because of MOM failure. Okay, I talked about this electrical complications being arrhythmias. Okay, even stoppage of cardiac arrest. Okay, that is also electrical complication, or MOM failure. That means that might be electrical impulses is there, but your ventricles and atriums, they are not contracting adequately. That means it is failing to pump the blood, but it cannot be detected from ECG. ECG seems to be okay, but your BP goes down because it's not pumping adequately. So for that, I told you in the previous slides as well, there are one thing is even you have to give resuscitation to the patient. Okay, external, or sometimes to prevent immediate electrical complications, there should be a patient with a doctor with defibrillators. Okay, DC shock given to the patient to help the heartbeat longer. Survival of the patient depends upon pre-hospital management with rapid deployment immune system with capable of CPR and defibrillation. So wherever in the hospital or in the ambulance where there is a the ambulance is going to get the patient, or the patient is coming to the ER, there should be a team. May not be a team of doctors, but there should be team of people, professionals who are capable of performing good CPR and giving defibrillation, DC shock if necessary. Okay, this is the primary thing. So if I have talked about all these basic drugs what we give, but order. So what basically these are the things that will happen when you go to the hospital. Okay, so there will be it will be divided in early and late management. Early management, these things will be repeated. Okay, so now this is in chronological orders what we do. Okay, for example, I talked about aspirin at the end of that 1 2 3 4 up to 10 methods, but aspirin should be given in the first time. Okay, I have now mentioned here. Immediate measures, immediately what should we do? High flow of oxygen should be there. Okay, and I talked about aspirin 300 mg, sublingual chewing. Okay, sublingually, and again sublingual nitroglycerin should be administered or given immediately. Okay, and if and then if possible, if the health facility allows, then IV analgesia, opiates or pethidine or morphine should be administered to the patient. And because of this pethidine and other apprehension and other things, there might be vomiting in the patient might vomit. Okay, and if the patient is conscious, okay, the vomit may go out. Otherwise, it may get ingested, it may get aspirated towards the lungs, so the patient might get aspiration pneumonia or die because of aspiration towards into the lungs. So to prevent that, antiemetic, metoclopramide, and other drugs is very essential for the patient. Okay, and IV access, I'm not talking about giving fluids immediately. Okay, IV access, that means opening your vein, opening the patient's vein and keeping it open is quite necessary immediately when you take hold of the patient. And then ECG monitoring. Okay, so ECG monitoring should be the first thing in diagnostic test performed, but that doesn't mean that while preparing for ECG these things should be done simultaneously. Okay, ECG before going for the ECG, because it takes time at least 1 minute to go to take the ECG machine to the patient. Within this time, without wasting any time, you give this aspirin, nitroglycerin, and others to the patient to save the life, and then ECG. Okay. So, so after ECG, you have established the cause, established that this is MI, then detect and manage the cause, acute complications like acidosis, arrhythmias. Arrhythmia will be diagnosed by this ECG only. Acidosis, we have to send the blood for ABG, arterial blood gas. Okay, CHF, evaluating your CHF, BP, and ischemia by evaluating by ECG also, which how big is that ischemia. Okay, and for that, for improving the ischemia, we have drugs like nitroglycerin. Okay, and vasodilators. So another step that we do depends upon how big is the center you have taken the patient to. Okay, so if it's a large center, then we can have PCI, that means percutaneous coronary intervention, mechanical intervention. Okay, so you find your artery somewhere, especially in the femoral artery, then make your way towards the heart, and then find the blood vessel that has been occluded, and then mechanically you dilate it or place a stent. That is what you need to do immediately. That will prevent most of the cases. It will prevent the further infarction, reinfarction. Okay, but many hospitals do not have these things. So for those, we have to use thrombolytic drugs like alteplase. So this is the place where you do, and this, you know, that this should be done as early as possible. Within 4 hours is going to be the best thing to do. Okay, why? Because there will be no within, if you do this within 4 hours, then the MI will not be evolved or it will not mature. Okay. So apart from this early management, the late management is there. So late management will be, now you have saved the patient's life, so the risk of dying of that patient is quite low. So there you have asked the patient for lifestyle modification, stop smoking, diet, weight control, lipid lowering drugs, regular exercises, and then diet. Okay, all these diet, fatty diet, on all the modern diets we have is the cause of this MI. So we have to explain these things to the patient. And secondary prevention, that means to prevent further MI, reinfarction and other things, we use the drugs like antiplatelet drugs, statins, antiplatelet being aspirin and other clopidogrel, statins for lipid lowering, beta blocker to modulate the heart's function and to prevent reinfarction and reinfarction, AC inhibitors to prevent reinfarction and to prevent CHF, okay, and other drugs if of diabetes and hypertension, like comorbidities like this, then we have to deal with those appropriately, okay. And mobilization and rehabilitation. Now the patient needs to learn how to live with the not properly functioning heart, okay, malfunctioning, not malfunctioning, but subpar heart, okay. So that means your heart is now already compromised. With a compromised heart, how are you going to live? So that is thing we have to rehabilitation of the patient. So last but not the least, what are the drugs that should not be mixed? Okay, drug interaction. All angina medication, except everything that we talked about, except these statins, aspirin, and fibrinolytics. Okay, all the drugs lower your BP. So mind it, lowering BP too much will be problematic for the patient. Okay, so we have to use these drugs carefully. Caution using angina medication with other drugs that lower the blood pressure. So I have been talking about this. Avoid other drugs that can cause GI irritations. Okay, why? Because GI irritation will add upon this pain and apprehension. Okay, avoid using two drugs that reduce the heart rate if possible. So beta blockers and verapamil. You can see verapamil is non-dihydropyridine that has a negative effect on heart, and beta blockers. Okay, and sometimes even other drugs that will have the similar effects should not be combined if possible. So this is all for today. I hope you understood today's class. But if you have still any questions, then this is the time you can ask. No questions? If no questions, then this is all. Today we have completed this ischemic heart disease.